Welcome to Decode Your Skin. Today we will discuss about structure of apocrine glands and Fox-Fordyce disease. This is the picture showing the epidermis, the dermis and subcutaneous tissue. This is acrine glands which opens into the skin and which releases the sweat, and this is sebaceous gland which opens into the hair follicle, and this is apocrine gland which opens into the hair follicle. The introduction. There are three types of sweat glands. This based upon structurally and functionally distinguishable types: acrine sweat glands, apocrine sweat glands, and apocrine sweat glands. Picture showing this is acrine sweat glands which opens directly into the skin, and apocrine glands which opens into the hair follicle, and sebaceous glands which opens into the hair follicle. These are apocrine glands. This opens directly into the skin. Apocrine sweat glands with the hair, sebaceous glands, develop from the primary germs or hair germs during 4th and 5th intrauterine life. Anersion of apocrine glands probably develops in all hair follicles, but after 5th month the most begin to regress, so that by the term the glands persist only in few sites like axilla, areola, periumbilical region and anogenital region. So they become functional at around puberty under the influence of ongoing hormonal activity. Their development is dependent on sex hormones, not their functional activity. Apocrine glands are coiled secretory tubules that open into the hair root above the opening of sebaceous glands. This is a sebaceous glands. These apocrine glands opens into the hair follicle or hair root above the opening of sebaceous glands. Sometimes it also opens into the skin surface. This picture shows the glomerulus secretory tubules, and this is excretory duct which opens directly into the hair root. These are larger than sebaceous glands, and so these are extended into the subcutaneous tissue. The location of apocrine gland is axilla, genital areas, areola, nipples, periumbilical area, vermilion border of lips and perianal area. So modified apocrine glands are mostly seen in external ear canal as ceruminous glands, eyelid, Moll's glands, breast, mammary glands. Apocrine glands are composed mainly of three segments. These are mostly intraepidermal duct, intradermal duct and secretory portion. Intraepidermal duct and intradermal portions of the duct are usually straight and are lined by the outer basal cells and inner luminal cells. The secretory portion consisting of single layer. This is the picture showing the secretory cells consisting of single layer of secretory cells, whereas in acrine glands only secretory portion is present, but entire secretory cells and no ductal cells are seen in acrine glands. The outer layer also has myoepithelial cells. Myoepithelial contraction helps in the pulsation secretion of the apocrine duct. So the lumen of secretory portion is large, measuring of 200 micrometer in diameter, 10 times that of acrine sweat glands. Composition of apocrine sweat. Apocrine sweat is cloudy, milky, viscous, initially odorless at a pH of 6 to 7.5. Apocrine sweat contains three types of precursors, mostly fatty acids, sulfonyl alkalis and odoriferous steroids. These are converted by the bacteria on the axillary skin, mostly the bacteria is Corynebacterium striatum, into the odoriferous substances. Presence of axillary hair also makes odor even more pungent because of secretions. Debris, keratin and bacteria accumulate on the hair. The secretion of amino acid and steroid precursor is controlled by an ATP dependent efflux pump multidrug resistant protein MRP8 encoded by a gene ABCC11. Mode of secretion. In earlier it was described as an apocrine secretion because it was believed that the secretion was separation of apical cap which was formed during maturation of the gland, hence the name apocrine. But now it is said that it is a merocrine secretion, as the picture shows the pinch of apical portion of the cell from the layer of secretory portion. So the apocrine sweat glands is a pulsatile. It is assumed that the contraction of myoepithelial cells and surrounding the secretory cells are responsible for the pulsation. Control of secretion is mainly the apocrine sweat glands respond emotional stimuli only after puberty. stimulated by the epinephrine, norepinephrine, which are given locally or systematically. Apocrine sweat glands are controlled by the adrenergic agonist. Sometimes it may be also by cholinergic control. So drugs that affects adrenergic system also has effect on apocrine sweat glands. Adrenergic neuron blocking agents inhibit sweating. So PPAR gamma may function as signaling molecule in the secretion. The functions of apocrine glands begins only after the puberty, and these are mostly odoriferous sexual attractants, territorial markers, warning signals, increase in functional resistance and tactile sensibility, increase in evaporative heat loss. Ion reabsorption in the sweat duct. The left hand side is shows as a luminal part and the right hand side is a basoluminal part. Firstly, the ion reabsorption of the sweat duct, sodium enters into the from apical site into the cell via epithelial sodium channels, and chloride enters into the cell via cystic fibrosis transmembrane regulator chloride channel and is transported across the luminal via a paracellular pathway. This is the down one which shows paracellular. The chloride enters from luminal side to basal side via paracellular pathway, and H plus is generated by with the help of carbon dioxide and water in the presence of carbonic anhydrase enzyme. These break down into the H plus and bicarbonate. H plus is thrown out to the luminal side via H plus V ATPase, and bicarbonate is thrown out to the basal side when the chloride is enters into. This maintains the pH homeostasis into the sweat duct. Applied aspects of apocrine glands. Obstruction of follicular infundibulum at the apocrine gland duct insertion site is apocrine miliaria, Fox-Fordyce disease, and its hydradenitis suppurativa also a disease which causes due to the obstruction of follicular infundibulum at apocrine gland duct insertion site. Other offensive or unpleasant body odor from the apocrine and ecrine gland secretion is bromhidrosis. Secretion of colored apocrine gland sweat, which is yellow color, green color, blue or black, which is called chromhidrosis. Fox-Fordyce disease is also known as apocrine miliaria, a rare itchy and chronic papular eruption that is localized to the apocrine gland bearing areas of the body, which are predominantly seen in females and age of 13 to 35 years in 90% of cases, but rarely seen before puberty and post-menopause. Seasonal, climatic and geographic occupational factors do not influence the development or course of the disease. Clinical features. The disease typically manifests after the onset of puberty, and most common site is axilla. Lesions manifest as grouped, symmetrically distributed, monomorphic, dome-shaped papules measuring of 1 to 3 mm. These are follicular based, flesh colored to mildly erythematous and intermittently pruritic. So excoriations and lichenification are often secondary to the scratching. Axilla, most commonly affected area, and other sites like pubic, perineal, areolar, umbilicus and sternal areas. Diminished sweat production is frequently observed in the affected areas. This is the picture showing flesh colored, monomorphic, symmetrically distributed papules with a follicular based, mildly erythematous in the axillary region. The second picture showing flesh colored papules based, follicular based and around the areola in the breast region. Etiology is Fox-Fordyce disease present at puberty and remit after menopause, and improvements also seen during pregnancy with the use of oral contraceptive pills. Hormones like alteration in follicular stimulating hormone, estrogen and premenstrual urinary gonadotrophins. Genetics, Turner syndrome, small deletion on chromosome number 21 may also has influence in causing Fox-Fordyce disease. Laser hair removal. After laser hair removal, the laser induced Fox-Fordyce disease like eruptions are seen due to the thermal damage to the follicular infundibulum and altered keratinocyte maturation and plugging of apocrine gland duct insertion site. Eruptions tends to occur several months after laser hair removal. The triggers for itching in the disease is stress, sweating, excitement and humidity. Pathophysiology of Fox-Fordyce disease is mainly due to Hyperkeratotic obstruction of follicular infundibulum at the apocrine gland dump insertion site. The intraluminal obstruction leads to glandular distension and eventual ductal rupture. So the expulsion of glandular contents into the surrounding dermis, and that causes an inflammatory response which manifests clinically as intensely pruritic and dome-shaped perifollicular papules. This intraepidermal sweat duct obstruction is another trigger for the disease. The histopath picture of this shows mainly hyperkeratosis of infundibular epithelium and dilatation of follicular infundibulum. Perifollicular and periductal xanthomatous cells are seen, and focal spongiosis of upper infundibulum along the perifollicular advential fibrosis. Vacuolar alteration at dermatoepithelial junction of infundibulum, smattering of dyskeratotic cells. Pathognomic feature of Fox-Fordyce disease is sweat retention vesicles. This first picture is showing follicular infundibular and excretory duct of apocrine gland with dilatation and hyperkeratosis and plugging. This is second picture showing histopath picture of Fox-Fordyce disease in the nipple area, which also shows the dilatation of follicular epithelium, follicular infundibular epithelium. Differential diagnosis for Fox-Fordyce disease, we have to differentiate it by for irritant contact dermatitis. In irritant contact dermatitis, there is a history of irritant and allergens, in most commonly seen in the axillary area because of due to the use of deodorants. And chronic dermatitis, we can differentiate it by the irritants and atopic history. Lichen nodulus, we can differentiate it from Fox-Fordyce disease. It's most commonly seen in children and young adults in the genital region. Lichen amyloidosis is, we can also differentiate it from Fox-Fordyce disease as it's most commonly seen in shin of tibia. And granular hyperkeratosis, syringomas, these are most commonly seen around the eyelids. And infectious folliculitis. Infectious folliculitis most commonly presents with pustules over the follicular region. So early stage of hidradenitis suppurativa, we have to differentiate this hidradenitis suppurativa and axillary papillary mucinosis and scabies and axillary perifollicular xanthomatosis. Management. Stress reduction and heat avoidance helps to minimize the pruritus. First generation oral antihistaminics for itching and low dose doxepin less than 10 mg up to 3 times a day can be used on alternative to antihistaminics. Thick creams and lotions should be avoided, and no evidence suggests that shaving and deodorant use worsens the symptoms. Selective therapeutic strategies for Fox-Fordyce disease is symptomatic therapies like oral antihistaminics and low dose doxepin, topical therapies for short-term steroids, and calcineurin inhibitors like 1% pimecrolimus and 0.1% tacrolimus. Tretinoin, adapalene, these are less commonly used because of burning sensation, and clindamycin in propylene glycol solution. Oral therapies like isotretinoin and oral contraceptive pills. Procedures like intralesional steroid injection, intralesional botulinum toxin injection, surgical excision, and microwave thermal ablation. Topical steroid creams, first line therapy and temporarily relieves itching. Continuous application for more than 10 to 14 days that causes skin thinning and formation of stria. Intradermal triamcinolone may help in itching during acute flares. This can also cause cutaneous atrophy with repeated administration. Calcineurin inhibitors like pimecrolimus 1% and tacrolimus 0.1% is used alternative to the steroids. These are used twice daily for 8 weeks, shows a complete remission. Topical isotretinoin is often abandoned because of its irritation to the skin, and adapalene of 0.1% gel, mild to moderate improvement in an itch and number of papules. It causes an erythema and burning sensation. Topical clindamycin in propylene glycol. So rapid resolution of papules are seen after 1 month without reoccurrence for up to 9 months. So other treatment modalities are oral isotretinoin at the 15 to 30 mg dose daily for 16 weeks. This induced near complete remission for lesions and pruritus. Diethylstilbestrol and oral contraceptives, testosterone and corticotropin. Ultraviolet light therapy once a week for 4 to 6 weeks to produce exfoliation. One-time injection of botulinum toxin type A. 2 units are diluted into 2.5 ml of 0.9 saline at multiple points 2 cm apart in the axilla. This produces complete remission 15 minutes after injection without recurrence at 8 months of follow-up. The procedural therapies There are variant procedural therapies for Fox-Fordyce disease that are electrocautery, excision and liposuction with curettage, microwave dermal ablation and laser based excision. All these are very late line options because of concern about the infection, and the procedures causes infection and hypertrophic scarring and disfiguration. Thank you.